Care Considerations. We have a wonderful panel, group of panelists here today. Dr. Anna Maria Crawford from Stanford University, Dr. Nicholas Suarez, American British Cowdrey Medical Center, Mexico City, Dr. Theogene, University of Rwanda, Dr. Gaston, also from the University of Rwanda, Dr. Tony Own, International Emergency Services, Myanmar, Dr. Aaron Hennessy from Stanford University, Dr. Javier Lorenzo, Stanford University, and Dr. Fred Neem at Stanford University. Thank you everyone for joining us today. We're very excited. Just some short Project ECHO etiquette and housekeeping. As we've mentioned before, our programming is based on a foundation of love and respect. Please respond kindly rather than react if you disagree with something. We will be using the chat function for questions and answers today at the bottom of your screen. Please send all questions through the chat box and feel free to introduce yourself. We're also going to be having several interactive polls, so please participate if you can. Please turn on your video and position your webcam effectively to show your face if alone or to capture the whole group. If you have any IT issues, please send us a message through the chat to ECHO IT and we will be happy to assist you. The session is being recorded and your attendance is consent to be recorded. Thank you. With that, I think we're going to get started. And I'm going to pass it along to, I'm sorry, I should mention interpretation. Thank you. In order to use interpretation, we have French and Spanish for our session. So please look at the bottom of your screen, bottom right, there's an interpretation button, and you can choose to mute the English part of the session or listen to both, and the translation will be louder than the speaker. If you click on the interpretation button, you can choose, as you can see, either French or Spanish. Okay, great. I'm going to pass it over to my colleague, Dr. Crawford, now to get us started.
Hello, everyone. Welcome. Just wanted to share my screen so that you can actually see the Learning Resource Center, which we will be using to highlight all of the content that we will cover today. So as mentioned, I'm an anesthesiologist and also board certified in critical care medicine, practicing at a few hospitals in around the Bay Area of San Francisco, California. I'm also the creator and editor of the Global Anesthesia and Critical Care Learning Resource Center. Just want to first thank our partners, Assist International and Project ECHO. We're grateful also to the WFSA for some of the work that we're able to do to educate people around the globe. I just want to remind the participants that the discussions and the content on the Learning Resource Center serve to promote exchange of knowledge and experiences of healthcare providers. These discussions are in no way intended to replace the clinical judgment and independent decision-making of qualified healthcare professionals. The creators and administrators of the Learning Resource Center make every attempt to provide up-to-date and accurate information. However, the information changes rapidly. Creators and authors cannot claim responsibility for inaccurate information. Individual healthcare providers are responsible for adapting this information to fit availability of resources and standards of care in their own institutions. Just a note on conflicts of interest in our pledge to learners. The Global Anesthesia and Critical Care Learning Resource Center aims to bring high-yield, evidence-based, and peer-reviewed resources to learners, regardless of their resource setting. We pledge to keep education open access and free. We pledge to keep the education free from advertising. We pledge to uphold ethical standards, and we pledge to approach all learners with compassion. Assist International is an international nonprofit organization, and the Global Anesthesia Learning Resource Center has received no financial compensation or advertising incentives other than within these partnerships. So with that, we'll get started with our case. You can see on the Learning Resource Center, we have several different courses, and today we're going to be working within the Oxygen series. Okay. You can see within the oxygen series, we're working in the oxygen and critical care case-based discussion series. And today we're going to be going through part 6. Okay, I'm just going to minimize this side panel here so we can see the entire case. Today, we're going to be talking about Mr. T. He's a 46-year-old man, and he presents with hypoxemia and respiratory distress. And we're going to focus on the basic ICU care considerations for this patient. Throughout the case, you will see some practice change objectives and action items related to these objectives so that you can not only learn the material, but you can actually take action to change your practice and improve care for patients. So our practice change objectives today are to identify the minimum standards of intensive care units, to identify the key healthcare providers in an intensive care unit, to discuss the types of monitors needed in an ICU, to list the specialized equipment needed, list the most common indications for ICU admission, understand and prevent the most common complications that occur in ICU patients, and review or develop and implement ICU care bundles for your ICU or your critical care patients. And we're going to use this case example to highlight those objectives. So again, Mr. T is 46. He has a history of obesity and type 2 diabetes. He presents to the emergency department after 3 days of shortness of breath, cough, and fever. He appears well, his breathing is non-labored, and he's speaking in full sentences. Previously, in 2012, he had a laparoscopic cholecystectomy, had his gallbladder removed. He doesn't smoke, he doesn't use drugs or alcohol, and he lives with multiple family members. He works in an office as a water engineer. His vital signs on arrival include a heart rate of 98, a blood pressure of 127/63. His respiratory rate is 30. His temperature is 36.5. His SpO2, or oxygen saturation, is 87% on room air. The plan is that he has been placed on a non-rebreather oxygen delivery mask at 10 liters per minute, and his SpO2 improves to 92%. The emergency room physician places a call to the ICU on-call physician. So my question at this point to learners is, what is an ICU? You can use the chat box to answer the question. So just when you think of an ICU, how would you define an ICU? So please share your answers in the chat box. ICU does stand for intensive care unit. That's correct. Okay, so someone is saying a unit in the hospital that can provide constant monitoring. So monitoring is definitely a large component of ICU. What else? Critically ill patients are admitted. At least oxygen and monitoring of vital signs. A unit that can intubate. Sick cases are admitted. They need constant observation. Doing lots of little things well while avoiding iatrogenic injury. Great. So there's a lot of components to the intensive care unit, and we took 3 definitions outlined by 3 ICU professional societies and put them in a word cloud that you can see here. And you can see lots of different words came out. And in addition to ICU and patients, you can see that support, life-threatening, and monitoring were key components of the definitions of intensive care. So at this point, I'm actually going to turn over the discussion to my colleague, Dr. Nicholas Suarez.
Hi, good morning to everybody. So now we're going to talk about our first practice change action item, which will be in this case to identify the minimum standards of an intensive care unit. Okay. So I don't know if we can move to the next. Yes. Okay. So as we can see in here, we have like a small definition. An ICU is an organized system for the provision of care to critically ill patients that provides intensive and specialized medical and nursing care. That is really important. An enhanced capacity for monitoring and multiple modalities of physiologic organ support to sustain life during a period of life-threatening organ system insufficiency. So as we can see, we can summarize, it's like to deliver a really high standard care to patients who are going, as we can read, through a life-threatening organ system insufficiency. So that will lead us to our first question, which will be...
This is a poll question that we'll launch for the audience to answer. Okay, so you can actually answer this question in the poll box. Yeah, and the co-hosts and panelists, please don't answer it. We'll close the poll.
Okay, so the question is, which of the following are standard components of an intensive care unit? So first we have continuous monitoring. Second, we have specialty trained healthcare providers. Third, we have system for delivery of time critical care. Fourth, we have specialized patient care equipment. Fifth, we have rapid access to the diagnostic and therapeutics. And finally, all of the above.
So I love these poll results, Dr. Suarez. Do you see that they're almost all the above? They all agree that number 6 is the correct answer.
Exactly. We have a 99% of our audience voting for that. So yes, as we can see, let's wait for the time. Yes, we have all the results already in, right, Anna? Yes?
Yeah, I think so. Yeah, I think we can close the poll.
Okay, so
all of the above.
Okay, so all of the above was our answer, and indeed, this is the correct answer. We have all of these components make an intensive care unit as a unit that can work like a rapid response and with using all the resources and all the human resources we need to attend a patient in a specific situation. So now we will explore the answer further to describe intensive care medicine. We will hear this time from Doctors Javier, Erin, and Vanessa as they discuss the minimum standards of an ICU as outlined in the different societies. For example, the WFSICCM, the CICM in New Zealand and Australia, and in the European, which is the ESSE. Okay.
Perfect. So we have multiple ICU societies, as mentioned by Dr. Suarez. He gave a portion of the definition of ICU from the World Federation of Societies of Intensive and Critical Care Medicine. But we're also going to hear from the College of Intensive Care Medicine of Australia and New Zealand, as well as the European Society of Intensive Care Medicine. So we'll start off now with Dr. Javier Lorenzo, and he'll tell us a little bit more about one definition as outlined by the World Federation.
Hello, everyone. My name is Javier Lorenzo. I'm an intensivist and anesthesiologist here in California. The World Federation of Societies of Intensive Care does provide a unifying definition of ICUs of different degrees, and essentially aligns well with what we spoke about earlier about the need to constantly monitor patients who are critically ill, critically injured, but it also goes into some details about the physical space of the ICU. It provides some recommendations about how to actually design the physical space and some of the requirements for the space. It describes the need to have personnel that is certified in the care of critically ill patients, so nursing and therapists and physicians who are trained in the care of the critically ill patient. And it also divides the ICUs into 3 levels, level 3 being the most sophisticated type of ICU that can provide so specialty care, and level 1 being an ICU that still has the ability to monitor, but doesn't have a lot of other subspecialties available at all times. So this essentially is a definition provided by the World Health Federation that takes into account definitions from other international organizations across the world. And it, like I said, it defines ICU as a place where constant monitoring needs to be available. The machine that can deliver organ support needs to be available, personnel that has the training to deliver that type of care. And it subdivides the ICU into 3 levels, tertiary, level 3 being the most sophisticated. Are there any questions on that definition?
That's great, Dr. Lorenzo. Thank you so much. So I think that the definition outlined by the World Federation is pretty similar to the other 2 societies. So maybe we can hear about the definition from what's commonly known as SICM in Australasia. And I think Dr. Hennessy has some information on how that organization outlines the minimum standards of ICU.
Hi, thank you. I think that the College of Intensive Care Medicine organizes the ICU similarly to what Dr. Lorenzo was speaking about previously into 3 different levels of the ICU. One of the things that is most specific on what the different levels should be able to do. So a level 3 ICU should be able to take care of complicated patients for an indefinite period of time. Moving down to the level 1, where patients should be able to have immediate resuscitation and care, and then with constant communication with a level 2 or a level 3. One of the most important things outlined in this standard of care is the staffing requirements. They go into great detail on what type of staff should be available in the different ICUs, specifically nursing care and medical direction. They do recommend that each pod of patients is about 8 to 15 patients, with a nursing ratio of 1-to-1 for all ventilated patients or 1-to-2 for lower acuity patients. They also recommend having a nursing supervisor who is certified in critical care, and then having more nurses for the acuity of the patients. They recommend having staff that can specialize in other specialty therapies, such as respiratory therapy, social workers, radiographers, dietitians, and technicians, and that there should be ongoing education of the staff that are dedicated to this unit. Everybody in the unit should be under the direction of the specialist of intensive care medicine, including the charge nurse and the medical director. And they go into detail of the structure of the ICU, outlining that there should be equipment for medical imaging, office space, specific patient areas, as well as the ability to isolate and provide isolation rooms for infection control, working areas, and a safe environment. They
Perfect.
also outline.
I'm sorry, Dr. Hennessy.
That's okay. I was just going to comment that they also outline the specific equipment that should be available. And we can see that if you scroll down quickly. And this is, of course, equipment for ventilators, suction apparatus, airway equipment, monitoring, equipment to control temperature in specialized beds.
Yeah, this is I really actually prefer this document to some of the others because it is so explicit in what is needed for an intensive care unit, but it's also very concise. And I think for some of our learners that don't have access to an ICU, this makes some of the needs of establishing a place to care for critically ill patients a little more accessible. So for learners that are looking to increase resources to care for critically ill patients, I would recommend this SICM document. It's only 14 pages as opposed to some of the other documents out there that describe minimum standards for an intensive care unit. And I think it does a great job of talking about design of the actual physical space. It talks about all of the equipment that is needed and monitoring that is needed, and then also the human resources that are necessary for ICU care. So I really like that document. Another one that we can discuss is the European Society of Intensive Care Medicine. Our colleague Vanessa Moll works in Switzerland and Germany, and unfortunately is unable to make it here with us today. But I just want to quickly show the audience that we do have yet another example of an outline of the minimum standards of intensive care. And it talks about the basic requirements, structural organization, and organizational aspects of ICU care. All three of these documents are available to the learners on the Learning Resource Center. If you click on that question within the case studies, or also if you are able to click on, let me see if I can move this, the paperclip here. You have several documents that are available for download. So you can run this session offline, and you can also download these documents up here. So those are all available to you for further review, even after the session. So great. So let's continue to move on. I'll go ahead and introduce the next practice change action item, which is to identify the key healthcare providers in an intensive care unit. We do have a case update. Mr. T, despite 10 liters per minute of oxygen by non-rebreather mask, his saturation decreased to 89% and his respiratory increased to 32. Now he's only able to speak 2 to 3 words at a time, which is significant that his breathing has become more labored. So does this patient need the intensive care unit? And if so, why? And if not, why? So you can type your answers in the chat box. Does this patient need to be admitted to an intensive care unit or higher level of care? Dr. Meem, at your institution, would you admit this patient to the intensive care unit?
Yes, at our hospital, this change in the patient status would indicate a need for closer monitoring. It would also be influenced by how quickly this change occurred as to the urgency to get him into an intensive care unit.
Yeah. Dr. Teo, at your facility, would this patient be admitted to the intensive care unit?
Yeah, as you can see, the patient is already on 10 liters of oxygen, and yet he desaturated at 89%, which means that he can deteriorate quite quickly. He's already starting to use his accessories for the respiration, so he can head quite very easily and get a cardiac arrest. So he needs to be in a unit that can monitor or can act promptly to save his life by providing the oxygen in another way rather than a face mask.
Right. Wonderful. Yeah, and I think just by those two answers, it goes back to the definition of intensive care, and it also highlights some of the key components of providing critical care. You know, one thing that we talked about in our last session is critical care is really time critical care, and it can occur anywhere, even outside of an intensive care unit. But the key is to recognize the patient is ill, to recognize the patient has, you know, a high propensity for decompensation and becoming worse. And so when a patient is this ill, they really do need a higher level of monitoring, which is one of the key parts of providing critical care, whether inside an intensive care unit or outside an intensive care unit. So we're going to launch another poll question about staff in the intensive care unit. So which of the following are essential staff for an ICU? ICU trained nurses, ICU trained physicians, respiratory therapists, also known as physiotherapists, pharmacists, cleaning janitorial staff, and all of the above. This is wonderful. So we'll stop the poll there at 1 minute, and almost everyone answered all of the above, which is what I would consider to be the correct answer. So Dr. Hennessy had discussed previously through the SICM outline of the minimal standards of ICU, the different types of staff that that should be available for critical care provision. And I think most of us that work in ICU consider it a team effort, and we are very used to working in teams. But I'm wondering, Dr. Hennessy, would you mind just giving us your opinion about why for example, cleaning and janitorial staff is important, and pharmacists and physiotherapists, in addition to specially trained nurses and physicians?
Yes, I think this is the perfect example of the team management in the ICU that improves patient care. It allows you to have interprofessional collaboration to provide the best care for the patient. For example, pharmacists can help guide antibiotic therapy, make sure that there aren't any drug-drug interactions, and make sure that correct dosing is used in the ICU. And the cleaning and janitorial staff is extremely important for infection control. And this does come into play when you have limited beds and limited resources, and you do need to turn over the rooms quickly to provide care for the most critically ill patients. And you will need their help on your team to make sure that this is done correctly to keep your patients safe.
So some of our learners in some areas with perhaps lower resources don't have physiotherapists or respiratory therapists. That's not common everywhere across the globe. I'm wondering if you can just describe a little bit more what a respiratory therapist, how they can be helpful for ICU patients.
Right, so respiratory therapists they provide care specifically for improving oxygenation and ventilation and what we call pulmonary toilet, so improving secretions and the ability to breathe. And what they do is they assist on your oxygenation devices. They can help with improving oxygenation by using different devices. They also assist with the non-invasive ventilation. They're also great resources for how to help patients mobilize while on these devices to get up and get moving. And so they provide kind of an extra level of care just specifically to oxygenation and ventilation.
Great, thank you. Dr. Teo, at the University of Rwanda in Butare, do you have respiratory therapists? And if not, who would perform those functions in your unit?
So definitely we don't have the respiratory therapist, but we do have physiotherapists within the hospital. So they have to intervene at least twice a day in the ICU, and the rest of the work is done by the nurses.
Okay, thank you. Okay, so I have another question for the audience. Which of the above providers could improve the care of our patient, Mr. T? And how would they improve this care? So within this specific example of Mr. T, who's now on 10 liters of oxygen, Dr. Nicholas or Dr. Tony, which of these staff could help Mr. T?
I think if you have respiratory therapist, then it can prepared for, probable ET intubation and a ventilator care setting ready. And also, ICU trained physicians who can manage airway and the ventilatory care. So at least, I would like to have respiratory therapists ready, as well as the ICU trained physicians ready.
Dr. Nicholas, what equipment would you tell your respiratory therapist to make ready for Mr. T?
Okay, so we will need a ventilation bag. If we are preparing for intubation, we will need our mechanical ventilator also ready, and with most of the parameters all calculated also, and we will need all the nurses and the rest of the staff to help us with medication that he will probably need for before and after the intubation, because he will probably require it with that clinical status. So yes, I think we need all the personnel that it's named there.
I agree.
Yeah. So you and Dr. Tony have outlined some really great points around if a patient does deteriorate to the point of needing intubation and mechanical ventilation, there are many different equipment items, medications, and procedural things that need to be prepared. And so respiratory therapists, nurses, and physicians should all work as a team to make ready. One person can't do this alone, so it's definitely a team effort. Dr. Lorenzo, are there any other oxygen therapy devices for this patient, or does this patient need to go straight to intubation and mechanical ventilation?
Yeah, that's a good question. There potentially could be other oxygen delivery methods that can be trialed before we place the patient on the ventilator. One of those could be the delivery of high flow oxygen. So it's oxygen that exceeds either 6 or 15 liters a minute, which is usually the maximum that can be provided by the wall source oxygen. So this is oxygen that can go as high as 50, 60 liters a minute. It's humidified oxygen because it is oxygen that's being delivered with high flow. So that's one method. We can also provide non-invasive support. That might not be particularly indicated in this case, but that's another way we can deliver ventilatory support without putting the patient on the ventilator. So that's putting a mask that can provide a continuous pressure. So that's what we call CPAP, or when we distinguish the two pressure between inspiratory and expiratory, the bilevel pressure, that's what we call BiPAP. So those are three other methods that can support respiratory failure before we consider the mechanical support of just putting the patient on the ventilator.
Yeah, in previous sessions, we had talked about the escalation of oxygen therapy, and we talked about moving from things like the nasal cannula to the non-rebreather. And then in some upcoming sessions, we'll also discuss high flow nasal cannula and non-invasive ventilation. Maybe not available in all institutions, but another thing you can do is actually add a nasal cannula and a non-rebreather together, and sometimes that may actually help the patient just a little bit too. So we can discuss those in our next sessions, but for this session, we'll continue on to talk about the basic ICU care considerations. So we have a new practice change action item, and that's for us to discuss the types of monitors needed in an intensive care unit. We have a case update. Mr. T is transferred from the emergency department to the ICU after evaluation by the ICU physician. He's placed in an isolation room with negative pressure as a person under investigation, or we call them PUIs, for COVID-19. He continues oxygen therapy with the non-rebreather mask, but the flow was increased to 15 liters per minute. Again, this goes back to some of our previous discussions about oxygen therapy escalation. And with a non-rebreather mask, you can use it anywhere from 10 to 15 liters per minute. So this ICU physician or care physician decided to increase the flow and see if that would help. So, which monitors should be placed on this patient? So answer in the chat box, what monitors need to be placed on this patient? Pulse oximeter, great. What else? EKG, oxygen saturation, temperature, blood pressure, cardiac rhythm, vital signs monitoring, EKG, blood pressure, great. So everybody recognizes the core vital signs that need to be monitored in a critically ill patient. So Dr. Meem, would you mind just outlining what you would consider the mandatory vital signs for an ICU patient?
Sure. I think routine vital signs would be heart rate and blood pressure, respiratory rate, an EKG to detect arrhythmias, as well as heart rate, and saturation monitoring with a pulse oximeter, especially in a patient like this who's suffering from respiratory insufficiency.
And we often check a lot of those vital signs on a regular ward or on the floor in the hospital. What is the difference between monitoring on the floor versus monitoring in the intensive care unit?
Well, the most important difference is frequency of assessment of a patient like this, and also some of those monitors might not be applied on the ward. Like some patients wouldn't necessarily have an ECG monitor.
Mm-hmm. Yeah, wonderful. What would you say is the best monitor in the ICU?
Is a person.
Yeah, exactly. I was hoping you would say that. Yeah, the bedside nurse or the physician that's at the bedside watching the patient. Your patient actually gives you the most information, don't they? But I think that does come with experience, recognizing when patients are sick or not. In any setting, I've noticed that not everybody recognizes sick patients. So thank you. Okay, next question. Which of the following is not a patient monitoring requirement found in most ICUs? Electrocardiography, pulse oximetry, arterial blood pressure, transcranial Doppler, respiratory rate, none of the above are required. So which one is not found in all ICUs? And Dr. Suarez, I'm going to ask you to discuss the answers if you don't mind.
Yes, as we can see, we have like 3 other answers. I think it's definitely transcranial Doppler is not a patient obligatory monitor requirement found in most of the ICUs. For that, we need specialized or trained physicians or maybe radiologists who could do it. But as I can see, maybe in some ICUs, they don't have pulse oximetry or maybe arterial blood pressure monitoring. I think all of them are really important. As Dr. Min just said, definitely transcranial Doppler, and most of all to a respiratory patient will not be a obligatory requirement for this patient. So now if we move on a little bit, we can start a discussion with Dr. Teal about the limitations of arterial blood gas monitoring in Rwanda, and what is your experience? What are your problems with this when you need to take a sample and analyze it, and how is it done there?
Thank you very much. Indeed, the arterial blood gas analysis is useful for ICU patient, but in most settings like ours, this arterial blood gas is not always available, or it's not available at all in so many settings in our country, and I guess in any other low-income country. So the challenge to get this arterial blood gas analysis is not the cost of the machine per se, but rather the cost of the equipment and the reagent. And as you may know, all the cost for the healthcare provision in our countries is paid by the patient. Although most of them, they have, I'm talking about Rwanda, they have a medical insurance, but the cost of the arterial blood gas analysis is very high. So it can ruin most of the medical insurance, since as the indication of the arterial blood gas analysis in our settings can be the traumatic brain injuries, the patient on a vent, septic patient. So we need to take samples quite a lot of time per day. So the cost can become a little bit not affordable for common patients. And the second one, as the arterial blood gas sampling should be done almost several times in a day. And we need to put an arterial catheter, indwelling arterial catheter. And there are not so many staff skilled to put an arterial catheter, but also, most importantly, those arterial catheters are not available, although we can use the peripheral IV catheters, but the limiting factor for the ABG is generally the cost. There are some point of care ABG machine that can be used, and we have samples of some of them, but still the cost of one cartridge comes out of reach of so many patients. So that is the biggest problem. So that is why most of the time we rely on the pulse oximetry.
Okay, interesting. So in that line, so could you discuss with us the pulse oximeters used in estimating the PF ratio via the Kigali modification of ARDS? So we are using another different parameter, so we can discuss.
Yeah, thank you very much. As when we decide to provide that definition of the ARDS, modified definition from the Berlin definition, it was just because we don't have ABG readily available for each patient, and not every patient has chest X-ray on bedside. But when I come back to the SpO2 and ABG, there was different studies, especially a study that has been published in Chest, I think in 2007, that was showing a quite good correlation between the SpO2 and oxygen saturation in arterial blood. So we took that formula from that publication, and we adjusted to the altitude of our settings in ICU in Kigali, for instance, to try to come out with a modification of what could be the ratio PaO2, FiO2 that was surrogated by the SpO2 over FiO2. And we found out that 313 should be a reasonable cutoff for a PaO2 over FiO2 of 300. That is one part of the definition, and I think we shall maybe discuss this in extenso for the next session.
Yeah, thank you, Dr. Teo, for mentioning that. We are going to have another session on ARDS, and so we will talk a lot about the Kigali modification of the Berlin definition of ARDS, where many places don't have access to arterial blood gases, and they can actually use their pulse oximetry to estimate that ratio and define ARDS. Nicholas, if you don't mind, before we move on to your next question, can I just ask Dr. Teo, for that question that lists the patient monitoring requirements, what would you consider the required monitors in your intensive care unit, since you are working in what we would consider a low to middle income country in Rwanda? So what are the mandatory monitors that you place on your critically ill patients? I think Dr. Teo is perhaps frozen with his Wi-Fi, maybe. Yes, Dr. Teo, what are the mandatory monitors for your ICU patients in Rwanda?
Yeah, thank you very much. For us, based on what has been presented, I think we do have the EKG available that can analyze the ST segment and the arrhythmia. And we have quite available non-invasive blood pressure, the respiratory rate is monitored, and the pulse oximetry. That should be large enough for a level 1 ICU, as I can say, in our setting. Of course, the staffing and...
Wonderful, thank you. Back to you, Nicholas.
Okay, great. I think that was a really interesting discussion, and it brought a lot of information. Thank you, Dr. Teo. So now I would like to ask Dr. Fred, how does the bedside monitor detect respiratory rate, please?
Well, there are some electrocardiographic machines, monitors, that have an extra ability to monitor impedance changes in the EKG leads. So while they're doing the normal EKG, they're also sensing the impedance, electrical impedance through the chest between the leads as they change with respiration. So if someone takes a breath in, their chest expands and the leads separate a little bit. And it's that separation that increases the impedance. And then so that the respiratory efforts can be counted pretty accurately. I would point out that respiratory rate is one of the most inaccurate physiologic variables if they're just done by someone observing someone breathing. And so in the ICU, I think it becomes more important as patients are more ill to monitor respiratory rate very carefully. And in this type of patient, it may give you an indication of another problem aside from his hypoxemia. It might suggest that he's failing to do the work of breathing and is developing CO2 retention, which could be a second reason to need to intubate him. And pulse oximetry, of course, doesn't give us much of a clue about that at all.
Yeah. Thank you very much, Dr. Mu. Back to you, Anna.
Thank you. Yeah, I think that's a great point, Dr. Main, that the work of breathing is something that we really need to keep our eye on. And in fact, is arguably a better monitor for the level of support that the patient needs, is really observing the patient themselves and see how hard they're working. Even if their numbers look okay, if they're working very hard to get to those numbers, they may need help from us. So before we get into the other types of monitors needed in the ICU, I just wanted to give everyone a case update on our patient, Mr. T. Now his heart rate is elevated at 102. His blood pressure is 117/52. His respiratory rate is a little bit higher at 32. His temperature is 37.5, but his SpO2 has somewhat improved to 91%. So I'd like to ask the audience next, in addition to the patient monitors that we've outlined, EKG, pulse oximetry, blood pressure, respiratory rate, etc., what other types of monitors are needed in the intensive care unit? So in addition to patient monitors, are there any other monitors or alarms that we set in the intensive care unit? And we'll let the audience answer in the chat box for a minute, and then we'll get the panelists to have a discussion about other types of monitors in the intensive care unit. Thank you, Sabine. Room temperature, capnography, ABG. What are some other monitors that we use? ABG is arterial blood gas. What else? Blood sugar. These are all very patient related. Are there other monitors in the ICU besides what we use for the patient? Okay, we'll just move on. I think maybe I didn't ask the question very well, but I think that we need to recognize that we have lots of equipment in the intensive care unit, and that equipment also has alarms and monitoring systems. So from the panelists, from anyone, what other alarms and monitors do we often see in the intensive care unit? Maybe we could hear from Dr. Hennessy or Dr. Lorenzo about alarms and monitors.
Sure. Well, when a patient is mechanically supported by a ventilator, that ventilator has some alarms like pressures that are, really high, or if the patient is breathing too small tidal volume, or the minute ventilation is too high. So the ventilator gives us some pressure and some volumetric volumes if too high or too low. When patients are connected to a dialysis machine, the dialysis machine can also give us some alarms, like the pressure needed to withdraw blood to the dialysis machine is too high. That's one other monitor that we can get from dialysis machine. When we put the patient also on a mask, like a non-invasive CPAP or BiPAP, that can also give us some monitor, some feedback, whether the patient is getting enough tidal volumes or we have too much of a leak. So those are three machines that give us really important values when they alarm.
Excellent.
Yeah.
Others,
Oh.
yeah. Or Fred, yeah, Fred too.
Go ahead, Aaron. Were you going to say something?
I was just going to say, I'm seeing some really great things in the chat. So that the apnea alarm that goes off when patients stop breathing is really important. The monitors on the infusion pumps are really important too. That will alert the nurses if the infusion pumps have run up or if they are obstructed or clogged and not flowing forward to the patient. I think another alarm that we can use, most of them are going to be auditory, so that if your nurse or your physician isn't staring at the screen, they can still be alerted. And one of them can be for the pulse ox. So you can turn the tone on for the pulse oximeter so that you can hear the drop in the oxygenation and or the change in the heart rate. And then also alarms for your upper and lower limits of heart rate and blood pressure are pretty important.
Yeah, we talked about tone modulation previously when we had our basic oxygen series and talked about using the pulse oximeter. So tone modulation is something that we often use because it gives us some idea of the actual pulse oximetry reading. And Dr. Meme is a big advocate for using tone modulation during procedures, so you can actually hear what's happening instead of having to stare at the screen. Did you have some other ideas around other monitors in the ICU, Dr. Meme?
No, I was just going to bring up about the pulse oximeter because it's a different alarm than our other alarms that just hit thresholds and then they have a noise. That's the same regardless of how far above or below the threshold you reached, and pulse oximetry is the only monitor that has that tone modulation that gives you audible degrees of concern or change that's that you can pick up just by listening.
Wonderful. And a couple things I would like to just maybe point out as well. When you work in a higher resource setting, you actually have other alarms and monitors of the equipment itself. For example, if you have pipeline oxygen, you can actually have an alarm that tells you that there's a problem with the oxygen system. If you have beds that are patient rooms that are negative pressure, isolation rooms, if that negative pressure isn't held, you can actually have an alarm that is built into the room's engineering systems as well. So there are other types of alarms. And I think, as Dr. Mean pointed out very astutely earlier, the bedside nurse is a very, very, very valuable monitor, because they're beside the patient continuously in the ICU, because Dr. Hennessy discussed the ratios of 1:1 to 1:2. Uh-oh, I just actually gave you maybe an answer to the next question, sorry. So for the audience, what is the recommended maximum nurse to patient ratio for critically ill patients in the intensive care unit? I sure hope you get this, since I just gave you the answer. Okay, so we actually have mixed results, but I think almost everybody recognizes that when you have critically ill patients, you need to really have the nurse available. So if we click on this question, there is a resource available. So very high ICU level care, level 3 care with critically ill patients. The nurse to patient ratio should really not exceed 1:2. When you have telemetry units or lower levels of care, you can have more patients per nurse, but for critically ill patients, it really should be 1:1 to 1:2. In our experience for the ICU in which I work, it's often 1:2, but a patient who's very sick on mechanical ventilation and perhaps has multiple infusions running, etc., we will actually make that patient 1:1. So there's just one nurse because they're so busy taking care of that one very critically ill patient. So I think this conveys the value of human resources and having very well-trained nurses and having enough nurses. Nicholas, do you want to get us started on the next practice change action item?
Yes, of course. So our next practice change action item will be to list the specialized equipment needed in intensive care units. And for that, we have a question which will be, which of the following specialized equipment is least likely needed in the care of Mr. T, our patient? So it will be airway equipment, mechanical ventilator, manual ventilation mask and bag, external ventricular drain, or suction apparatus. Okay, so as we can see, definitely an external ventricular drain will be at least likely needed in the care of Mr. T. As we know, Mr. T is a respiratory patient, so we can have a really good, we see a really good answer with an 84% of the poll. So definitely we will need airway equipment. As we discussed earlier, we will need a mechanical ventilator if we proceed to intubation and mechanical ventilation. We will need a manual ventilation mask and bag because we will probably need to prepare him for intubation, and succious apparatus for all the secretions that the patient may have once he's intubated or maybe before the intubation. So that will lead us to another question. And I would like to invite Dr. Min and Dr. Lorenzo and Dr. Tio and Dr. Gaston in different perspectives about what other specialized equipment is common and helpful in the care of ICU patients. What do you think we need or these patients need for their ICU admittance?
I think the airway equipment, mechanical ventilator and the ambi bag and the suction machine are definitely mandatory. But for this particular case, I don't see any other equipment apart from the equipment for the airway. Maybe you can monitor the urine output as well. I don't see the need of a cooling machine or whatever. So from my perspective, I think those are the most important for this particular case.
Yes, I think we're obviously already including the usual monitors that we would have for this patient, the EKG, pulse oximetry, blood pressure machine. So I'm not sure we need much more than that. The suction equipment can be very important though. So it's the ability to help clear secretions may be an important factor in whether he survives even. So I don't want to overlook that need for adequate suctioning.
Yeah, I think that those equipments listed are the primary equipments that we would use for a patient in respiratory failure like Mr. T. If we were to put an invasive line, the ability to transduce pressure from that invasive line might be a useful equipment to also use. If Mr. T ends up being intubated for a long time, it might be helpful to also have some lifting equipment, the ability to help him mobilize, have a specialized beds that allows him to sit and do some physical therapy while he recovers from his respiratory failure. That might be some useful equipment as well.
Wonderful. I'm going to move us along just because we're running a little bit behind, which is fine. But so next we want to talk about the indications for ICU admission. And I just want to recognize that ICU admissions vary depending on country and context. Different populations, different communities have different disease patterns and risk factors. So there are lots of different reasons why patients can be admitted to the intensive care unit. In the United States, for adult patients, the 5 primary ICU admission diagnoses for adults are respiratory insufficiency or failure with ventilator support, acute myocardial infarction, intracranial hemorrhage or cerebral infarction, percutaneous cardiovascular procedures, septicemia or severe sepsis. There's also admissions for poisoning and toxic effects of drugs, pulmonary edema, heart failure, shock, etc. For pediatric patients admitted to PICU, it's usually acute illness exacerbations in the setting of chronic problems, so respiratory illnesses, some other cardiac diseases, neurologic disorders, etc. So I'm just wondering, because indications for ICU admission do vary based on the community's factors, I'm wondering if Dr. Dr. Nicholas can tell us what's most common in his ICU, and then perhaps Dr. Hennessy can tell us what's most common in her ICU, and then Dr. Teo can maybe give us some ideas. Those are 3 different practice settings. One is in California, one is in Mexico City, and the other is in Rwanda. I'm afraid for us now at this day and age, it might all be COVID, 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 but outside of COVID, what are the most common indications for ICU admission? And we'll start with Dr. Nicholas, if you don't mind. I'm unable to hear Nicholas. Dr. Hennessy, would you mind sharing your perspective about what you see most commonly admitted to your intensive care unit?
Sure. So I work in 2 different ICUs at Stanford, and one's a cardiac-based ICU and one's a med-surg-based ICU. And I would say right now, we do have a high percentage of patients for respiratory failure related to COVID-19. But when we aren't in the middle of a pandemic, in our medical units, we do see a high rate of patients admitted for respiratory failure, heart failure, and also we take care of the patients who have had strokes or intracranial bleeds. And then our patients in the cardiac unit come in for cardiac surgery, percutaneous cardiology procedures, as well as we are able to offer ECMO support for oxygenation. And so we have a large different type of patient population, but respiratory failure is still very high on the list in our medical surgical ICU.
Great. Dr. Teo, what are your most common diagnoses for ICU admission in Rwanda?
So almost 1/3 of the admissions are from sepsis, and especially intra-abdominal sepsis, they come in post-op, but we see also quite often a lot of trauma, including traumatic brain injuries. And we see also some respiratory failure, especially due to pneumonia, and some seasonal cases of acute severe asthma. But most important is obstetric admission that can represent even almost 10%. And among them, we have cases of sepsis, post-op sepsis, post-cesarean section sepsis, PPH, preeclampsias, some cases of peripartum cardiomyopathy. But nowadays, we see also quite often cases of cardiovascular diseases, including complicated hypertension with stroke and ischemic stroke, but also it depends where there are availability of dialysis. We can see also quite cases of acute kidney injuries from malaria, from sepsis, and also cases of end-stage renal disease because of untreated hypertensions and diabetes mellitus.
Yeah, very interesting, totally different patient populations. And even within the United States, I actually work in a different ICU than Dr. Hennessy and Mim and Lorenzo. I work on the other side of the bay and work in a public hospital. And our common diagnoses, obviously now is COVID, but outside of COVID, we actually see a lot of unhoused or homeless population. And so we see a lot of overdose from drug use. We also see a lot of diabetic ketoacidosis. We see a lot of really end-stage medical problems. So a lot of congestive heart failure, renal failure, liver failure, et cetera. And then we also see a lot of trauma in our ICU. So indications for ICU can be many, but most often it's intensive monitoring and support of organ failure. I would argue across the board, that's what the intensive care unit does. So next, we're going to move on to common complications in the intensive care unit. So even though it's very, very important to develop capacity for caring for critically ill patients, a lot of what we do does unfortunately come with complications. And so there are pretty common complications in the ICU. So our next practice change action item is to understand and prevent the most common complications that occur in ICU patients. But again, I want to put this in the context of Mr. T, who is our case. He is beginning to look fatigued. He's less awake. He has altered mental status. He has labored breathing. He's looking dusky or cyanotic, and he's asking for help to breathe. If a patient ever asks you for help, you should probably intervene and help them. So his heart rate's now 102. His blood pressure has gone down a bit to 97/51. His respiratory rate is 37, and so that tells us he has a really increased work of breathing. And now, despite being on the 15 liters by non-rebreather mask, his saturation is 87%. So what clinical steps should be taken to care for Mr. T? Dr. Lorenzo, what would you do for Mr. T?
Well, it's clear that Mr. T is struggling to breathe, and he's breathing with a high rate that is tiring him out. So at this point, I would prepare to support him. So we can prepare to provide mechanical support and prepare to put him on a ventilator. I try to get some other diagnostics to see if I could figure out why he's having such hard time breathing. If I have the ability to image his lungs with an X-ray, I would like to do that, since there are some quick interventions that perhaps can be done if his respiratory distress is due for a pneumothorax or a collapsed lungs. But at this point, it's clear that he needs help. He's asking for help. He's breathing with a respiratory rate that is not sustainable. So I would be prepared to mechanically support him.
Wonderful, thank you. Yeah, I think you make some really great points in that, you know, his care is now very time critical, so we really need to intervene quickly. And I think one thing that, especially in places that are not used to caring for critically ill patients, I think one of the things that can be stressed is that you need to escalate care quickly because patients will decompensate rapidly. He should be closely monitored at the highest level of care possible. So if you don't have an intensive care unit, move him to wherever he can get the highest level of monitoring and care. And he should be evaluated by a physician or nurse who's trained in critical care if possible. If not, the highest trained care provider available should really come and evaluate Mr. T. Okay, we're going to move on to the next update. So this Mr. T is in a facility that has an ICU. So as the ICU team attempts to place Mr. T on oxygen therapy by high flow nasal cannula, he loses consciousness, so he passes out. And so the team moves quickly to successful intubation, and he's placed on a mechanical ventilator. He's now hemodynamically stable and under sedation on a mechanical ventilator. Next, the ICU team decides to place a urinary catheter and an internal jugular central venous access line for lab draws and to monitor the central venous pressures. So what are some of the common complications that occur in ICU care? You can put it in the chat box, but I also just gave you the answers in this nice little graphic. Dr. Teo, may I ask you, of these complications listed in this picture, which have you seen in your intensive care unit?
So many of them, but starting by the ventilator-associated pneumonia that is quite often seen in our settings. And we also have infection with drug-resistant microorganisms. We have a lot of DVTs because patients are bedridden for a long time. And of course, trauma and other cases. Malnutrition, definitely, because we don't have already industrial prepared food for ICU patients, so we rely on support from the family. That is a very big challenge. and muscle weakness, and some renal dysfunctions. And of course, as most of our nurses are not very well trained, we can face also medication errors. So I think the list is quite good.
Yeah, I think you actually make a great point about why the importance of ICU training for nurses and physicians, both, because there are a lot of complicated procedures and complicated medications and monitors and equipment. And so ICU training is really important. And that's one thing that we have worked on to expand in Rwanda, for example, but should really stress that this education is important for those reasons. I think one other thing that was placed in the chat box, which is great, is bed sores. So patients, if they're not turned regularly, can actually develop pressure ulcers. And so that's another very common complications. So for the interest of time, we'll move on and discuss care bundles. So how do we prevent these complications? Because there are so many complications that can occur in ICU. So our next action item is to review these care bundles and understand them. And if we're working in a place that doesn't already have them in place, to implement ICU care bundles to prevent these complications. So per the Institute of Healthcare Improvement, a care bundle is a structured way of improving the process of care and patient outcomes. It's usually small, straightforward set of evidence-based practices, generally 3 to 5, that when performed together have reliably seen to improve patient outcomes. So that's what a care bundle is. Next, we have specific care bundle examples. And so the first one is central line associated bloodstream infection. So I'm going to ask our master proceduralist, Dr. Fred Meem, to talk to us a little bit about how to prevent infections when placing a central venous catheter.
Yeah, certainly we've gotten smarter over the years about how to do this more carefully. And some of this is just common sense, I guess, when you look at this little diagram to remind us about what are the common sense things to do it as thoroughly as possible, which means to clean your hands and disinfect your hands even before you put your gloves on, and the gown and glove, and put a cap on your head and put a mask on your face, to be careful with the draping off of the site, to be cannulated so that the actual surgical or the area for the procedure is very carefully separated from other parts of the skin that hasn't been prepared, and to clean the area well with good disinfectants, and to be really careful about the dressing after the line has been put in. Our nurses have a very careful training in how to put the dressing on, and a careful list of interventions to make, and how often those dressings should be changed. So none of this is very sophisticated. It's just about being careful.
Yeah, I think you make really great points, and I would stress that masks are important all the time for preventing infections, especially in the setting of COVID, right? So some places have different levels of resources, but really when you're placing a central line, it should be at the same sterility level as a surgical procedure. And so I think this is a great resource. You can actually click on this document, it'll take you to some of the CDC resources. In higher resource settings, we often have disposable drapes and gowns, etc. But in some of the lower resource settings, they have reusable sterile drapes and gowns, which I would argue are probably actually better from an environmental standpoint, so you're not having so much waste. But for example, and if I'm not mistaken, Dr. Teo, in Rwanda, you actually have gowns and drapes that are made from cloths versus paper.
Both are available, but the one from paper must be paid by the patient. So to avoid an extra cost, you may have to use that in tissue or towels.
Right. Next, we're going to move to catheter-associated urinary tract infections. So this is another very common complication and infection found in not only ICU patients, but in any patient that has a urinary tract or a urinary catheter placed. So some of the things you can remember to do to care for these patients and to prevent urinary tract infections is to take the catheter out as soon as possible. If the patient doesn't need the catheter anymore, try to take that out. For male patients, instead of using the Foley type catheter, if you can use a condom catheter, that has a lower infection risk. This also needs to be inserted using sterile fashion or aseptic technique. And then also you want to make sure that the urine is not pooling. So the catheter and tubing itself should be drained down to gravity. But the biggest thing I would argue is that we take these catheters out, because if you don't have a catheter, then you don't have a catheter related infection. So that's for urinary tract infections. And we're so lucky, I'm just informed that Dr. Gaston has decided to join us. So we're very grateful for his presence as well. I'm wondering, Dr. Gaston, is it possible for you to talk to us a little bit about sepsis and septic shock and what we should do in the first hour we receive a patient who has septic shock?
Thank you, Tim. My apology for being late. There are 5 key elements of our one bundle in sepsis and septic shock, and as you have seen on the schematic show here, it's those 5 things are. So you have, first of all, to measure the lactate level. And the level of lactate is, when increased, it means like that somewhere one organ is not functioning well. So the normal, if it's beyond 2 millimole per liter, then there's a problem. So you receive patients, for example, the patient comes to the emergency, and maybe you see the patient there. Most of the time we receive patients in late presentations when the patient is getting more worse. And but in this case, wherever you see the patient, you have to measure the lactate level, and then obtain the number 2 is to obtain the blood culture prior to giving antibiotics. And some patients arrive in our settings when already the antibiotics have been given. So that's why this should be known by even the physicians that see patients, like in hospitals, not district hospitals, or where the settings are not highly advanced. So to obtain blood culture prior to administration of antibiotics. And then number 3, to administer broad spectrum antibiotics. And number 4 is to give fluids. The administration of 30 mils per kg crystalloids, that is still with hypotension and rectate more than 4 millimole per liters. Number 5 is to give vasopressors. If patient is hypotensive and during or after fluid resuscitation, that's to maintain the mean arterial pressure equal or more than 65 millimeter of mercury. So those 5 things is to key elements to consider in 1 hour bundle in sepsis and septic shock. And so the only problem with this is, when do we get patients just to deal with this? So if we receive patient, wherever you have a patient and you have signs of sepsis, septic shock, think about these 5 things. but there are many challenges where you can't measure the lactate, you can't do blood culture. Those are challenges most of settings have. So I don't know if someone has something to add or to talk about that, but that's 5 key elements to deal with.
Thank you, Dr. Gaston. Yeah, I think you make excellent points about resource availability. And I think as hospitals develop greater critical care capacity, that these things are known to show improvement in patients. So things like this should be prioritized. But if you don't have resources for all 5 steps, obviously giving intravenous fluids and antibiotics should really be prioritized for these patients, since those are the interventions available. And if you have adrenaline, that could also be given. So thank you. So we are going to move on, and there is a phenomenon known as post-ICU care syndrome. And so what we're going to do, since we have limited time, is just watch this video. It's about 3 minutes on what post-intensive care syndrome is and how we can avoid it.
Many people now survive critical illness. Healthcare professionals used to assume that patients who survived critical illnesses returned to how they were before. However, stories of patients with profound struggles after being hospitalized emerged, such as James, Maria's, and Ping's stories. James was a businessman. He had sepsis from a severe bout of pneumonia and needed life support for 10 days. For months after his illness, he was forgetful, had difficulty concentrating, and frequently lost his train of thought. James was asked to copy this drawing, and he drew this. Maria was a professor. She had severe influenza. Her kidneys and lungs failed, meaning that she needed dialysis and a breathing machine for 2 weeks. After her hospitalization, Maria had profound weakness. She had to learn to walk again at a rehabilitation center. Ping was in 4th grade when he was hit by a car. After being in the intensive care unit, or ICU, he went to a rehabilitation hospital. Ping talked little at rehab, but learned how to use his arms and legs again. He had a hard time reconnecting with his friends. During the past 20 years, research has confirmed that these types of stories happen more often than not. In 2010, the Society of Critical Care Medicine, or SCCM, gathered together experts involved in the care of ICU survivors. The group named the combination of problems common to survivors of critical illness post-intensive care syndrome, or PICS. PICS includes new challenges to the brain, body, and emotions, and is seen in more than half of critical illness survivors. Children surviving critical illness often have similar problems, such as delayed developmental milestones, learning problems, and sadness. Families and friends are also affected. For example, James' persistent problems led to his wife giving up her job to be his caregiver. Researchers are working to prevent and treat PICS. SCCM believes that ICU survivors can share their stories to help each other, which is why its Thrive initiative is building a network of face-to-face groups for critical illness survivors. In 2015, 6 Thrive sites were launched. In 2016 and 2017, even more will join. If critical illness has touched you or a loved one, please join us. Let's create a better recovery together. More resources about PICS and the Thrive Initiative can be found here.
So I think PICS is good for us to recognize. I'm sorry that video speaks very quickly in English, but it is available on the Learning Resource Center if you want to watch it again, and also know that it is available in Spanish as well. But because of PICS, the Society of Critical Care Medicine has started an initiative for the Icu Liberation Bundle. And I think it's just really important for all of us care providers to recognize that even if we can serve our patients well so that they survive the ICU, that there are still lots of complications that occur thereafter. So we're out of time, so I just want to quickly review the key topics of what we discussed and what we learned today. The ICU is a separate hospital unit staffed by specially trained physicians and nurses who work closely with other specialized staff to care for patients. ICU patients need intensive monitoring and support for failing organ systems. ICUs require specialized, continuous patient monitoring systems. ICUs require special life-supporting equipment. Indication for ICU admissions differ depending on resource availability, local risk factors, and the health of the local community. Critically ill patients in the ICU can suffer several complications that must be prevented and monitored. Care bundles can decrease these ICU complications, and post-ICU syndrome can have significant long-term impact on patients who have recovered from critical illness. Post-ICU care syndrome also affects the patient's families, and institutions should follow the guidelines for ICU liberation. So with that, I would like to return to my co-panelists and first offer great thanks for your time in educating all of our learners, and also to see if you have any closing comments or thoughts about basic ICU care considerations.
I was going to just make a point that for someone deciding to increase their capacity to care for critically ill patients, a good starting point is to look at what kind of patients they actually see, which ones, what type of patients, what diseases do they see most often, and that's the clue as to what those patients need. And if you don't have those things, the monitoring that they would be benefited by, then that's a good starting place with the patients you see most often.
Dr. Tony, may I call on you? I know that you currently don't have an ICU and you're in process of launching some expansion of critical care services for patients in Myanmar. And so what do you see as potential ways to use this information or to start to expand critical care capacity? If you could unmute yourself, sorry, we can't hear you.
Thank you very much, all the panelists, and I learned a lot. I do have a small ICU currently, like 4 bedded and 1 ventilators that we've been using, and we have some patients requiring ventilator care, and then shock, sepsis, and that kind of things. But then currently, we're going to expand the service and build in the about 14 bedded ICU. So the biggest problem is human resource crisis. So we are recruiting people, healthcare providers, doctors and nurses, and then train them like essential basic ICU care, physiology, pathophysiology, and how to monitor, how to track the training of the patients. And then, in terms of equipment, we can get it, but then the bottleneck is the human resource. In our countries, we don't have, many critical care nurses, and also, doctors trained to take care of the critically sick patients. So, training is the most important thing.
I think that's a common problem, Dr. Tony, and I think this is exactly why we have launched the Learning Resource Center and partnered with Assist International and Project ECHO, is to really help with the education component for ICU providers. Dr. Teo, you have been just absolutely critical in the development of ICU care in Rwanda. And so I'm wondering if you could share some of your experiences about how critical care has evolved in a place that may not have the same level of resources as a high-income country, and maybe offer some advice to learners on how to improve their own institutional capacity.
Yeah, thank you very much. So I think Rwanda has reopened the ICU per se in almost 2001 after the genocide, because it was there before the genocide, but after the genocide, there was no staff to run the ICUs. When we reopened, I was just a general practitioner with some nurses and 2 anesthesiologists who were running the theater and at the same time the ICU. So we started with cooperation with a French team who used to come and train our nurses and as general practitioners and anesthesiologists. Then after that, we had like a 5-bed ICU with maybe 3 ventilators, and all the beds were equipped with a monitor, with the basics, the monitors. But then after that, we have created such a huge demand, and we have seen that so many patients were needing ICU, and it becomes a little bit a challenge. And fortunately, we had another cooperation with the USA universities, and from that opportunity, we developed a course for ICU nurses, and they were trained on job. We trained quite a number of them, maybe 20, and we still run the course every 2 years. I'm fortunate to have one of the nurses who has had a course, who has graduated from the critical care nursing. Now he's running the course. I pass by and then give some explanation, and I think he does quite a good job. And even people from outside of the ICU are coming to attend the course. And I think it's a good resource for us, that kind of training, that kind of, even a single nurse who can train others can make a difference. So for the practice perspective, we have developed a kind of policies and some protocols, some guidelines, especially we have one on ICU bundles for management of sepsis, prevention of ventilation associated with quite common problem that we see in our settings, even for prevention of pressure sores. And for each of them, we have tasked one of the nurse as a champion in each point, so that he can provide some key statistics on a regular basis, so that they can discuss with colleagues and see what they can do. Although we are still a little bit struggling, but I think it's a good way we can hope for a better future in maybe 10 years.
I think you're a shining example, Dr. Teo, you and the University of Rwanda, of the things that we talk about in this session and in other sessions. Oftentimes it seems overwhelming and not possible, but I think if you have colleagues and you work together, you can really develop these protocols, guidelines, and policies and tailor them to your own resources. So thank you for sharing your experience. And to all the learners, just know that all of the resources on the Learning Resource Center are available to you. There's lots of information that you can download and use and adapt to your institution. And then we're also happy to answer questions offline via our WhatsApp thread. And again, I just really want to say thank you to all of these amazing panelists for sharing your knowledge and your experience with learners from all over the globe. So thank you so, so much. And thank you to our partners, Assist International and Project ECHO, for making this possible. So thank you. I'll turn it back over to Alana or Monica. Thank you also, Nicholas, who was a strong co-lead with me today. Appreciate you.
Thank you, Anna.
Hi, everyone. Yes, just to echo, thank you to everyone who's joining in to the session today. We have participation from over 130 countries around the world, so it's really wonderful to see all of you joining and participating and contributing to the discussion. As Anna mentioned, thank you to all of our panelists for sharing your time and your expertise. Thank you, Anna, for creating this course and directing this program. And thank you to our funders, the GE Foundation and Project ECHO, for making this program possible. I've shared some links in the chat. I just wanted to reinforce that the entire module covered today and all of the resources are available on the Learning Resource Center. On this platform, you can access the recordings, slides, quizzes, case exercises, and videos. So we do encourage you to sign up and access this, which is something you can do on both your phone or a computer. And then finally, to obtain a certificate of attendance for today, we have shared some links to complete a short feedback survey in the chat. And once you fill out the survey, you'll get your certificate. And then all of the information I've just shared about the Learning Resource Center and certificates will also be circulated in an email after the session, along with the video recording of today. So thank you, everyone. And if you have any questions, please don't hesitate to reach out. Our email is on the screen there. It's echo@assistinternational.org. So thank you again for joining, and we look forward to seeing you at session 7.